Today I want to touch on maintenance and prevention programs regarding 3 themes. The first is asking yourself, what is a maintenance and prevention strategy or program? Well, it's maintaining what you've achieved with treatment. In the musculoskeletal system, that is typically maintaining full joint range of motion that is painless, full muscle flexibility, full nerve extensibility, full muscle strength, among other things. And then if you maintain what you've achieved, that should give the benefit of preventing the recurrence of that same disorder. Now, this, of course, is not related to traumas that are outside of your control. For example, car accidents or even falls to a certain extent. Traumas occur to the body, including the musculoskeletal system, and there's only so much we can do to maintain a healthy body and prevent those types of accidents from occurring. So the focus is how can you maintain treatments that will maintain a healthy musculoskeletal system and prevent kind of lifestyle or cumulative or preventable disorders from returning, not accidents and acute traumas. So you have to frame it like that. And then if you have that framework, then you can go forward and say, well, what is the best strategy to maintain that? So if the goal is maintaining strength, well, what do you need to do to maintain that strength? Do I think there are disorders or problems where the lifetime maintenance program is a lifetime of doing strength training? I haven't really come across those. Strengthening is good, but I don't think for people with musculoskeletal disorders that aren't kind of more general outside the musculoskeletal system, you don't need to, for example, strength train your biceps 3 times a week for the rest of your life to prevent a certain disorder from recurring. That being said, I think there are a lot of people for whom they need to maintain full joint mobility. Now that's because full strength should kind of just be there, meaning you don't have to do extra to have extra above average strength to prevent disorders from recurring. And I'm arguing that you don't need to have above normal joint range of motion either. You just need to have normal range of motion. And I think for a lot of people, that requires a maintenance or prevention strategy because our lifestyles tend to, for many people, if not most people, tend to have us lose some range of motion because of the predominance of certain movements and positions of our joints and the lack of movements and positions that take the joints in other directions. So that first point about maintenance and prevention is ask yourself, what are you trying to maintain? And then go from there. How do you achieve that? Is it strengthening? Is it joint mobility exercises? Is it stretching? Is it practicing your balance every day? Look for the thing that will keep you normal. Again, keep you normal. Keeping someone normal is different than saying you need to be better than normal. You don't need to be able to do the splits to have normal hip mobility. That would be considered way above average joint mobility of the hips. Think about lots of things that professional athletes do, for example. Those are way above average. I argue that you need to maintain normal musculoskeletal health in order to have the best odds of reducing recurrence of a prior disorder or the advent of a new one that is outside of that trauma and acute injury bucket. So that's theme number 1. Theme number 2 is when we think about mechanical joint problems, which of course I think are the large majority of orthopedic disorders. I disagree with other clinicians, and you can see this because they're not diagnosing mechanical disorders. Ergo, they're diagnosing them as something else that would obviously down the road create a very different idea of a maintenance and prevention strategy. But for joint mobility disorders, what I would call a mechanical joint derangement in the parlance of Robin McKenzie, they can be attacked kind of in 2 different directions. Does a person need to add something to his or her life to maintain full pain-free range of motion of the affected joint, or do they need to subtract something? I would argue in my experience as a clinician and my experience as a patient, you need to do a little bit of both. For example, let's just say your neck has a problem, loses range of motion, and you get achiness on that left shoulder and left shoulder blade, and retraction of the neck repeatedly abolishes the symptoms and ensures that you have full pain-free neck mobility in all 8 planes. Well, maybe then the subtraction is if we find that protrusion of the neck over the course of hours through the day is negatively impacting your range of motion and will therefore subsequently create those symptoms, then reducing the amount of neck protrusion in your day, such as looking at a laptop or a desktop or a phone or a book, reducing that might be an effective strategy. The opposite, adding something to your life, is doing more neck retraction. And people can use trial and error to find out what works for the individual patient. As I'm telling my patients at discharge, finding a maintenance strategy for you is very individual. It might be you add an exercise to your life. It might be you subtract something you're doing in your day-to-day life. It might be you need this once a day, once a week, 3 times a day, only on the days where you do X. We got to figure it out. But we have these two kind of general ideas of addition and subtraction, and we need to play around with what works best for you. For example, if a patient feels worse with sitting in their low back, better with standing and walking, it might just be reducing sitting and walking more. But if the effective strategy in therapy was doing low back extension, then maybe doing that once a day, twice a day, once a week is effective. The end goal, going off of the first theme that I mentioned, the end goal for maintaining the reduction of a mechanical joint disorder is maintaining full and pain-free joint mobility of the affected joint. So for the patient with this neck hypothetical example, you need to do what you need to do that keeps your neck full and free, meaning all 8 motions have full range of motion and they're free from pain. So if adding neck retraction 3 times a day does the trick, do that. If subtracting a lot of protrusion and adding neck retraction once a week maintains full joint mobility that is painless, do that. I want you to understand the concept so then you can tweak the maintenance and prevention program to what works. It's kind of what I mentioned when I talk about posture with people. I am not the posture police, and I'm not the do your exercise police, but I am the keep your full range of motion police. I'm just arguing that the musculoskeletal system, in terms of joint mobility, should be normal. Now, there are certain joints in the body that I think all clinicians will agree, that's the amount of knee flexion we expect. That's the amount of elbow extension we expect. But I think we have vast differences in how much spine range of motion we expect as normal. Part of that difficulty is in the fact that when you move your neck, you're moving 7, 8, 9, 10 different joints, different levels of the neck and upper mid-back, upper thoracic spine. The same thing goes with the lumbar spine. But I still think most clinicians are really underestimating, for example, how much neck extension you should have, how much lumbar side glide you should have, how much thoracic rotation you should have. And they are allowing that the person has a limited range of motion because it's painless, and not pressing to see if more range of motion can be gained. If there's a natural average for people, a clinician's job is to say, well, you may fall within this normal average of range of motion, but that doesn't mean it's your normal. For example, if say an average is 5 to 10 degrees and you have 6 degrees, well, your normal might be 10. And the opposite is also true. You could have too much, that's quite rare. But the clinician's job is to kind of understand what normal averages or ranges are and apply them to the specific patient in front of her, because people are different and that's why these ranges exist. So for mechanical joint derangements, maintenance means keep that joint moving in all its planes without pain. And my job as a clinician with a patient is to say, these are the main 4 motions of your low back. You need to make sure if you want to test every day, it takes an entire 10 seconds. Can you touch your toes? Can you lean back all the way to the point that we've established is your full extension range of motion? If you can't ascertain if you have full extension of the lumbar spine in standing, let's do it on the floor where you can better feel and understand if you have full range of motion. You should glide all the way left and all the way right. And literally that test takes 10 seconds. I do it to my spine often, not every day. I don't have a plan, but I just check to see if it's moving well. Why do I check my lumbar spine? Because that's where I've had 3 major injuries that affected my life for many years. I do not check my knee range of motion every day, nor my ankle, etc., because they have not been problematic. But for the maintenance and prevention strategy, you need to understand if you have full range of motion. And if you are doing nothing, considering nothing about your lifestyle factors in terms of your positions and movements, doing nothing in terms of exercise addition to your life, and you have full pain-free range of motion, then there really is no argument that you need to change anything. But in my experience, with spines especially, if there was a previous problem that was based on cumulative lifestyle factors that arose, the maintenance strategy, once we've attained a normal range of motion, the maintenance program will have to somehow look at lifestyle factors. But if they don't, and you're doing well in terms of full range of motion, then you're fine. Again, it becomes a finer point to really define what is your full range of motion. Because I think a lot of people bend back 20, 30% in terms of lumbar extension. It doesn't hurt and they think it's good. And they're missing 70 to 80% of their range of motion. Or they think, hey, I'm in my 40s, I can only touch my mid shins now, but 5 years ago I could touch the floor, that's just aging. I would argue, I don't think it's aging, let's test. Because if we do the correct testing, repeated movement testing, and we gain more motion, then we know that your initial attempt was lacking, that you had a deficient or loss of range of motion. So the third point I want to make is that when we consider this bucket of joint mechanical disorders, which I'm finding again is about 75% of musculoskeletal disorders that other clinicians are not looking for because they're not using repeated movement testing as an orthopedic test. This test was developed by Robin McKenzie many decades ago, but has not caught on in academia, unfortunately, and therefore is not trickling down to clinicians and then to patients. For the patients who have mechanical problems, usually in the spine, not as much in the extremities, that need 2 or 3 different movements to resolve, then the maintenance program becomes a little bit more complicated in terms of deducing which movements are the most effective. And I give people kind of this spiel. If, let's say you have a lumbar problem, sciatica, L5 radiculopathy down the right leg, let's say repeated side glides on the right, reduce your symptoms in your leg 70%, and then extension gets it out of the leg officially, out of the back, that last 30%. Well, then you definitely have demonstrated you need both. In the future, could you attempt, I'm just gonna do side glides and see if I keep my full range of motion that's painless? Absolutely. You could also just test extension. Or you could say, I have 2 minutes in the day, I'm gonna do both just to be extra preventative. But you could tease apart, well, I feel it more in my legs, so I know I need side glides first. Or today I'm just feeling it in my back, I think I may need just extension. Again, it's individual. Patients have to do some trial and error, and when there's more than one exercise, it becomes a little bit more complex to think about which one do I need. Another thing to go off of, other than just symptom location, is which movement got you what in the therapy. So take away symptoms. If the side glide, say you're in the lumbar spine, there's 4 motions. Say your flexion, your forward bending is only hands to knees. Say the side glide, done repeatedly, hundreds or thousands of times, got your flexion to ankles. Then the extension got your mobility in flexion from ankles to toes. Well, then if you're really stuck in flexion and you can only reach your knees, then you probably need the side glide, not extension, because the side glide got you that amount of flexion before. That's a very simple kind of one-to-one, but you can kind of go back to the treatment and say, what got me what? What accomplished what? And as a clinician, I want to point out to them, look, the side glide got you your flexion back, or the side glide got you the pain moving from your thigh to your buttock, or the side glide returned your extension, but it didn't return your flexion. And therefore, when those signs appear down the road, you can use the maintenance strategy that is specifically geared toward that sign. Patients, I find, which makes sense, are more geared to understand their symptoms. They're more geared to understanding what they feel. But if they can do that extra little test, or if I speak to them, I can say, well, what's happening with your flexion range of motion? Then we can assign an exercise that match the sign to the exercise versus match the symptom to the exercise. So that's a little bit of an overview of how I think of maintenance prevention. If there's acute traumas, we're not doing a plan to really mitigate accidents. But for other disorders, you have to ask yourself, what did I start to achieve? What did I get back with my treatment plan? And how do I maintain that going forward? And having a good strategy is really important. And if there is a better way to maintain full lumbar range of motion, for example, than doing the 2 or 1 movements that we did in therapy, I'm all for that. If you're like, hey, I do these planks and I maintain full range of motion, or I make sure I jog 3 times a week and I maintain full range of motion, that's great. I want you to find whatever you find that works into your daily life, your weekly life, that maintains full range of motion. But I think so many disorders return, not necessarily because of loss of strength again, or loss of nerve extensibility or muscle flexibility again. I think the main issue by a long shot is that you've lost range of motion again. And that loss of range of motion is probably due to something in your day-to-day life in terms of how you're moving that joint, what range of motions it's going through, how it's positioned through the day, and if there's an imbalance. If your shoulder is only moving into flexion and external rotation with work, for example, are you ever taking your shoulder into extension and internal rotation? So think about joint mobility, because I do think that's really the thrust of kind of maintaining a good musculoskeletal system. It's number 1 in my book. And when you have a lens for what you need to maintain and you understand how lifestyle factors can affect them, then you can really pinpoint, how do I need to change ergonomics or things in my life? And how do I maybe need to add something to my life to counterbalance that, to stay in a good spot? And for a lot of people, especially with spinal disorders that are mechanical in nature, I will get a call a year or 2 or 3 years later, and we kind of just need to review that strategy because they had felt good and they kind of, as a patient a normal person, forgot about that going forward. But it's almost always the same thing that was fruitful before is the thing that's fruitful now. But a lot of people will just fall off on a maintenance program, and that'll get you, you'll get pretty far without it. But for most patients, as the literature conveys, back pain tends to recur. And if that back pain is due to a mechanical problem, which I find it usually is, then it's because the mechanics got off track again. And again, look for something in your life that's affecting your mechanics, affecting your joint range of motion. If you do that, I think you're, 3 steps ahead. Please leave comments or questions and share this with someone, who doesn't understand kind of how to maintain a good musculoskeletal system, or if they have questions, they can put them below and I'll do my best to answer.